So in Zurich, we have captured the data from 2017 to 2021. I have to thank Stefano Barco, who just presented the DVT experience also for this study. You see we have treated 161 patients in that time frame. A little bit more than half were men. The mean age was 68 years. Even 12% had cancer. 6% had surgery in the last 30 days. Concomitant DVT was found in 68%. It's quite a lot. The reason is we are scanning all patients with PE also for DVT, and you can see it's quite a lot of patients have also DVT at the same time. The PE location was central in the main pulmonary artery in 94%, and it was bilateral in 96%. ESC high-risk class, 12.4% of the cases, and the rest were intermediate risk patients. Troponin median level was 68, so quite some significant troponin release. The RV-LV ratio on the CT scan at baseline was 1.3. Next slide. So we also obtained the new score. The new score was not specifically designed for ECOS treatment for PE patients, but we think it is a good score because it contains the most important vital parameters. As you can see here, respiratory rate, O2 set, supplemental oxygen need, systolic blood pressure, heart rate, and also level of consciousness. Next slide. So what you can see here first, that the mean pulmonary artery in our series of 161 patients decreased from 36 millimeters mercury to 26 millimeters mercury. This is very consistent finding that we have seen in the Ultima study. So a drop by 10 millimeters mercury and mean PA pressure is what we can achieve with ECOS. What we also see that the new scores during thrombolysis drops. So that confirms that there's an early hemodynamic benefit already during the first 12 hours of ECOS treatment, where we see that the score drops from 5 to 3 after already 12 hours of ultrasound-assisted thrombolysis. Next slide. And most important, we had very good outcomes. As you can see here, we had only 2 major bleedings, so 1.2%, and we had only 1 patient who died within 7 days, so 0.6% deaths. So these data are very reassuring, showing that ECOS in patients with intermediate or high-risk PE can result in very good clinical outcomes. Next slide. Well, we had the pandemic. We don't know if it's over, but we have seen a lot of patients who had intermediate or high-risk PE on top of a severe COVID infection. You can see here images on the left upper with a severe COVID pneumonia. You see a dilated right ventricle, both in the CT scan and in the echocardiogram. And we are usually placing ECOS catheters also in patients with COVID. So question was, next slide, if the ECOS treatment is similarly effective in concerning hemodynamic assessments as compared to patients who have been age and sex matched from our database to the COVID patients. So similar comorbidities except the COVID. And what we see is that the drop in mean PA pressure in COVID and in non-COVID patients shown on the left panel is similar in these 2 groups, and the improvement of the new score was also very similar in COVID patients and in non-COVID patients. Next slide. So in conclusion, ladies and gentlemen, what we can say is that in patients with intermediate high risk or in those patients who have high-risk pulmonary embolism but without decompensation, that ultrasound-assisted catheter-directed thrombolysis was a fixed-dose TPA regimen of 20 milligrams over 15 hours, reverses right ventricular dysfunction and hemodynamic instability, and is associated with a very low risk of bleeding and mortality, as shown in our data and previous data. Of course, we will hear later in this session also about the higher PYTHOS trial, which will be the first large randomized trial looking at heart endpoints, which will be important for future guidelines. And we are quite convinced that those data will help us guiding future treatment for PE patients. Thank you for your attention.
Thanks, Nils. Do you have a couple of minutes for questions, or do you have to go and set up for your case now?
I have 2 minutes.
Yeah, okay, Nils. So all your patients in that 161 case experience were SPECE positive, right? So we're estimating a 30-day mortality of 10%, and your mortality is 0.6%. So that's looking good for high PYTHO, right? I mean, it's quite hard to argue with a mortality less than 1% that includes all SPECE positive and a proportion that are high-risk PE.
I completely agree. I mean, I would say it's difficult to beat also for other companies that come with new generation PE devices to beat these outcomes. Also, what we have to say is that placing an aqueous catheter into the pulmonary artery is not really an intervention. I mean, this is, I consider it as putting a central venous catheter. So the intervention by itself is a very low risk. So the really only risk is from the thrombolytic. And of course, we're using durations of several hours and doses of 1 or 2 milligrams per hour. So we're not reaching, I think, critical concentrations of TPA that are known to cause systemic bleeding complications. And yes, I think it looks quite good, the future, and what we will see what high PYTHO will bring us.
Yeah, and are you relying a lot on hemodynamic support to get those results, or is it just you're instigating so early on in the disease process in these relatively unstable patients that they're getting out of trouble before you need that support?
Yeah, I think we are quite aggressive here in Zurich. We are known for this. So actually, when I teach my attendings and fellows, I say, you have to give me a good reason not to treat this patient. So yes, maybe we are a little bit too aggressive and too early. On the other hand, we have to be honest. I mean, there is patients that are quite unstable when we do echoes. In those patients, we sometimes use a TPA bolus of up to 5 milligrams per pulmonary artery over the echoes device in order to, to shorten the effect of the thrombolytic. We are not using bolus in intermediate risk patients that are stable. I think very helpful is to use the mixed venous oxygen saturation. I mean, if it's 70, you have time. But if you have a patient who may have a normal blood pressure, but you already see when you puncture the common femoral vein that it looks dark blue, and then the MVO2 gives you a value of 40%, you know, this patient can be in high trouble very soon, and those patients we use a bolus to start.
Yeah, excellent. Well, I know you've got a case to go and prepare for, so I'll let you go. So thanks very much, Nils. Great results, and look forward to seeing you soon.
Have fun and talk to you later.
Yeah, cheers.
Thank you. Bye.